Okay, we'll just give it a few seconds to get a few more participants coming in.
I think we can start, Joanne.
Okay, great. We're just looking at the participant. So yeah, thank you all for coming today. And here we're doing the first of our webinars as part of the Stunting Hub, looking at the role of parasites and pathogens and the potential role they've got in gut health. And here we're particularly looking at the potential role of helminths, and we're at early stage. And what we're delighted is to have Dr. Montresor from the WHO, who is the focal point for intestinal parasites and the sort of all-round expert on intestinal helminths. He's a medical doctor, and he will be giving us a short keynote introduction about the helminths in general, the associations, the role with MDA. And then we're going to have two of the young students. We're going to give some of the work on systematic reviews, looking at the background and in terms of, is there a potential link between helminths and stunting, and what are the evidence gaps, and how are we going to be then focusing on that over the next few years in terms of the Stunting Hub. So yeah, I'm going to turn over now to Dr. Montresor, as I said, from the WHO. And he's going to give us the opening introduction. And what we will do is we will have questions all at the end after the three speakers have spoken. So it's a true pleasure to have you here, Antonio. Thank you very much. And we will pass you over for your keynote. Thank you.
Thank you, Joanne. Sorry, I was muted. So I'm Antonio Montresor. I work in WHO as a focal point for soil-transmitted helminthiasis. And I will give a brief opening note on this, on the nutrition morbidity caused by soil-transmitted helminth. I think there is an important fundamental issue that we have to remember when we're discussing about parasitic helminth infection, is that the helminth infection can be caused by few parasites or by thousands of them. And so, because the parasite do not reproduce in the host, each infecting parasite is resulting from a separate infection episode. And so, passing from an infection with low intensity to one high intensity is a slow process. It's not like bacteria that reproduce very, very quickly in the host. And another thing that's very, very important, in my opinion, is the fact that we have a dose-dependent morbidity. It's like smoking cigarette. If you smoke one cigarette a day, it's different if you smoke 40 or 2 packs of cigarette a day, and then the morbidity is different. The same is for the intestinal parasite, the soil-transmitted helminth. For example, in the case of hookworm, in the low-intensity infection, the blood loss caused by this parasite is not much different from what is normally lost in the gut. On the contrary, if you look at the heavy intensity infection, when we have a lot of parasite, a lot of worm in the intestine, we have an amount of blood lost that in a month is similar to the one that is lost during menstruation by a girl. So it's quite a large amount. And if a person is a girl, have menstruation plus have heavy intestinal infection with hookworm, of course, it's very difficult for her to have a normal level of hemoglobin. And also, we can quantify the amount of blood loss in the feces, the hemoglobin loss in the feces, by step of 1,000 hookworms X per gram. So for 1,000 hookworms per gram, you're losing 0.8 milligram of hemoglobin for each gram of feces. The same situation is for Trichuris trichura. If you have every worm cause a little amount of blood to be lost, but so if you have few worms, normally the infection is asymptomatic, while if you have more worms, like 400, 800 more worms, you have a substantial risk of anemia. And if you have high intensity, normally the infection, the infection associated with colitis, diarrhea, growth retardation, and tricuri dysentery syndrome, and mucosal bleeding. Again, for vitamin A and Ascaris lumbricoides, so each worm expresses a range of retinol binding proteins, and that allow the worm to utilize the retinol for its own growth and development. Of course, if you have few worms, the uptake of by the parasite of vitamin A is minimal. If you have a lot of worm, is a significant quantity. So fortunately, we have the catocats that enable us to really identify the infection morbidity of intensity quite easily. There are a lot of claim that the catocats is not sensitive enough. This is true for low intensity infection, but for us, low intensity infection are not so different from no infection. So it's very good to identify infection of moderate heavy intensity. And these are the classes of intensity. As mentioned, for light intensity from 1 to, this is per grams. This is not very severe in terms of morbidity, while for heavy intensity infection, the risk of morbidity is substantial. And of course, we have a sort of, we have irreversible morbidity, especially stunting, in which if a child during his childhood is not developing enough, then will never get up to normal nutritional level. It will remain always stunted. And but let's say that the intent of our control program is not to recover these children. Unfortunately, we can do a little, but to avoid the new morbidity cases. And here I have a very quick presentation on how is the strategy of WHO to control the morbidity of STH and also schisto. So basically, the natural progress of the disease, we have negative person, then we have light intestine infection, then the person continue to accumulate worms, infection, then reach infection of severe intensity. When we intervene with drug, mass drug distribution, basically we reverse this process and progressively we eliminate first the infection of heavy intensity, then the one of moderate intensity, and we remain with a cycle of negative and infection light intensity, but we don't give enough time to the person to get additional worms. So normally this cycle is positive in a way that is not causing any morbidity. And then this very briefly, we have three populations at risk of morbidity: preschool children, school-age children, and adolescent women. This is why this group, because they are the one who are the children that are growing, so they need all vitamin and macronutrient to grow. And then we have the woman of reproductive age, they are also losing a lot of blood, as mentioned, with the menstruation, and therefore we have to protect them to additional blood loss due to the infection, especially with hookworm. And the coverage of children of school-age children and preschool children is going quite well. We have a drop because of COVID, but in normal year, we are approximately around 60% coverage of the children in the world. This corresponds to 600 million children that are treated every year. But we have not enough, doing not enough for women or reproductive age. We have examined a large amount of survey, DHS survey, in which there are three questions that are particularly important. One question is if the girl or the woman received the worming during the last pregnancy, the childbirth weight, how was the childbirth weight, and the child survival. So we analyzed these three questions. And first of all, we see that only 23% basically of the women that we were investigated with DHS were treated. With difference in different regions, but in general, this is a low coverage compared to school children and preschool children. And then we analyze from 800,000 births, what is the difference on the child. And we see about neonatal mortality that this was reduced by 15%. So from 2.1 to 1.8 on the 200,000 that were treated compared to the 600,000 this were not treated. This is really individual data. You know how to work the DHS. And the same for low birth weight, we have a 11% reduction from 16.9 to 13.3. So it's not completely eliminating the risk of mortality and low birth weight, but is a significant at very low cost. And what we are doing now is we are trying to promote with a policy paper the treatment of these girls, and hoping that this will improve the health of the children. Thank you very much. My presentation.
Thank you very much, Antonio. That was absolutely super. And again, we'll see so critically these new studies coming up that we can see this, potential, the key hosts that need to be treated, the pregnant mothers and the school-aged children. So yeah, that's a beautiful background. Thank you very much. And so we'll come to questions at the end. So I will pass over now to Eleanor Raj, who is going to present a systematic review, some of which was performed just before these beautiful new studies coming out on the pregnant mothers and the impact. So Eleanor is a veterinary surgeon, and she did her master's in One Health with us at the RVC, gaining the highest distinctions. And she's now sort of complementing her work, doing a mixture of consultancy, including with FAO, with clinical work, and sort of combining the research and the clinical work together. So here she's going to present, as I said, some of the recent work of the systematic review to evaluate the potential association between Helminth infection and physical stunting in children. So over to you, Eleanor.
Thank you very much, Joanne, for that kind introduction, and thank you very much, Dr. Montresor, for the really interesting keynote speech. And so, as Joanne said, I'm going to be speaking about our systematic review that was looking at potential association between Helminth infection and physical stunting in children. Next slide, please. So just to provide a little bit of background, obviously Dr. Montresor has kindly already spoken particularly around Helminth infections, but in terms of stunting, it's a very complex and multifactorial concept. It covers both physical stunting, as Dr. Montresor showed on the slides, with the children that were shorter than they should be for their age, as well as cognitive stunting, where brain development is affected. And according to the WHO framework regarding stunting, a range of factors can affect whether children become stunted. And so those can include repeated bouts of infection, for example, with Helminths, nutrition or malnutrition, environmental factors, and maternal health. And data from 2020 showed that 22% of children under 5 years old globally were stunted. And you can see on the map there that in some countries, the levels of stunting were even higher for those children under 5 years old. And the children under 5 years old are the group that we generally refer to as preschool age children. In the definition of physical stunting, again, it's height for age that is more than 2 standard deviations below the WHO child growth standards median. And those growth charts or the expected growth charts for populations can be found on the website so that public health officials can monitor whether children are growing as we would hope. Next slide, please. In terms of Helminth infections, in our review, we were focused on soil-transmitted Helminths, schistosomes, and foodborne trematodes. There are obviously other Helminths, and in particular, they can lead to significant morbidity. They can cause mortality, but relatively, the levels of mortality are relatively low, but the morbidity is significant, and so these conditions are very disabling for people that are affected. They can be affected by conditions like anemia, as Dr. Montresor already mentioned, but also people can be suffering from abdominal pain, diarrhea, blood in their urine, and potentially liver cancer, depending on the type of helminth. And both stunting and helminth infections are strongly linked with poverty and the social determinants of health. And this means that it's often the most vulnerable in society that are affected. And our review is particularly relevant to several of the current global health targets, included in the roadmap for neglected tropical diseases, the global nutrition targets, and of course the Sustainable Development Goals. Next slide, please. In terms of helminth infections, there are several aspects that are relevant to One Health, which is obviously gaining momentum and moving up the agenda in terms of health. So there are environmental factors such as access to clean water, sanitation and hygiene that can affect whether people are likely to become infected. Many helminths are zoonotic, for example, Schistosoma japonicans. And there's also issues such as potential behaviours that could increase the risk of infection. So, for example, some studies have found that young children and sometimes pregnant women consume soil or mud, something called geophagia. And also, it's possible that we're starting to see antibiotic resistance in some human populations treated with mass drug administration, so that's relevant to the wider antimicrobial resistance topic. Next slide, please. So our review was obviously aiming to expand on previous research. Our hypothesis was that helminths cause physical stunting in children, and this is because it's very frequently cited in the literature, despite conflicting results. So we aimed to cover a wider range of helminths compared to some previous research. So often research is focused only on soil-transmitted helminths or schistosomes, but not necessarily try to include both together. And also most reviews have not tried to include foodborne trematodes. We also tried to include a wider range of study designs, so not just randomized controlled trials, but also pre and post studies, case series and case reports. And we were aiming for wider demographic groups than are usually included in these sorts of reviews. So as Dr. Montresor mentioned, we specifically wanted to include pregnant and breastfeeding women to try to capture potential in utero stunting and early childhood stunting. Next slide, please. So because stunting and helminth infections are very complex and broad topics to tackle, we set quite clear boundaries from the beginning for our systematic review. The PRISMA checklist is up on the slide. I know it's too small to read on here, but it's just to say that we followed best practice by using the PRISMA guidelines and also by following the Cochrane Handbook for Systematic Reviews. We also registered our review on Prospero and followed the usual steps for a systematic review in terms of developing a search strategy, literature searching, etc. Next slide, please. So we followed a PICO approach, which is relatively common, where we defined our problem, our intervention, comparison and outcome. So by breaking down our hypothesis and research question, we were focusing on young children, pregnant and breastfeeding women suffering from soil-transmitted helminth infections or schistosome infections or foodborne trematodes. And in terms of the intervention, we were looking for treatment with an anthelmintic. So, for example, albendazole, mebendazole, or praziquantel. And we were comparing groups that were treated versus controls, or infected versus uninfected, or pre and post treatment. and the outcome we were focusing on was physical stunting in children, so a subset of the population. And we searched through 7 databases for our review. Next slide, please. So I haven't listed all of our inclusion and exclusion criteria here, but they are in our paper. We specifically needed studies that included anthelmintic interventions so that we could try to investigate potential causation rather than just association. And as I said earlier, we registered with Prospero early on and prior to data extraction, again, following best practice to ensure that we try to think through issues such as risk bias and our planned synthesis methods. So how we were planning to analyse our results and synthesize them. And in the end, we took a combination of narrative synthesis and subgroup meta-analyses for preschool age children and pregnant women. And for this particular review, a meta-analysis of all the included studies was not feasible because of the significant heterogeneity between studies. Next slide, please. So our results, which you can see on the Prisma flow diagram here, we had 80 studies included in total, most of which focused on school-age children and soil-transmitted helminths. Our results overall did not support the hypothesis that helminths cause physical stunting in children, and this was consistent with a recent Cochrane review looking at deworming in children. Next slide, please. So our main finding, though, was the lack of available data in infants and preschool age children. So infants is referring to children up to 1 year old, and our preschool age children up to 5 years old. And this was a really important finding because these are likely to be the essential groups that we need to look at when we are trying to evaluate stunting, because we know that the first 1,000 days of life are widely recognised and acknowledged to be the most critical period for child growth and development. So this is between a period of conception and when children turn 2 years old. And previous research has shown that this is extremely important, this period, and so we need to get more data for this time. There are still relatively few studies that seem to consider the possibility of in utero stunting. And so this is something, again, that was found as an evidence gap through our review. And that's just the grade summary findings table at the bottom, which is something we use to try to look at the certainty of evidence. Again, as part of best practice when doing a systematic review. Next slide, please. So our review did have some limitations. So there was publication and language bias due to the inclusion and exclusion criteria. And we did find that most of our studies focused on school-age children. And as I've already said, we wanted data that focused on the younger children, so the infants and the preschool age children, to really be able to test our hypothesis in a robust way. And the chances are that this is because until very recently, young children were not treated as part of mass drug administration programs, and neither were pregnant women. So our results are relatively similar to previous systematic reviews, as I already said, but that's probably because we found relatively few studies covering schistosomiasis, and we didn't find any on foodborne trematodes that met our inclusion and exclusion criteria. Next slide, please. So overall, the lack of available data in these essential demographic groups was our main finding. So our infants and our preschool age children, as well as pregnant women and breastfeeding women. And as Dr. Montresor has already mentioned, these groups are very much vulnerable to helminth infections through anemia and other conditions. And we know that these first 1,000 days for children are absolutely crucial for their growth and development and can have long-term effects. So we really do need to get some more information for these groups. We also need studies to think about linking low birth weight and possible intrauterine growth restriction with childhood stunting. At the moment, they're often considered as separate issues, both from a clinical and policy perspective, but we know that they can be related. We also found a possible association between Helminth infection in children and wasting. And again, this suggests that we may need to think about malnutrition in a more holistic sense, rather than only stunting or wasting as separate issues. Next slide, please. So overall, our review highlighted some very key evidence gaps for future research studies, in particular in relation to these young children and our pregnant and breastfeeding women who are particularly vulnerable to these infections. In the context of childhood stunting, we really do need some better birth weight data. At the moment, we found that many countries are not recording birth weight data as consistently or robustly as it would be nice to see. So that's a relatively simple thing that can hopefully change. We did find that there were some challenges with age thresholds, and that does affect stunting because the definition, as I mentioned before, is a height for age ratio. So without knowing the age for sure, it can be difficult to know what sort of levels of stunting are current. And also our review was based on aggregate data, and this potentially could be interesting to explore further. We know from previous systematic reviews that there can be differences when reviews look at aggregate data versus individual patient data. So that's something to bear in mind. And at the moment, the relationship of stunting or wasting on the response to deworming treatment is still undetermined. So really, we just wanted to highlight these key evidence gaps for our preschool and infants. So our preschool children and infants, so less than 5 years old, particularly the babies, and also our pregnant and breastfeeding women. So that links in quite nicely to Isabel's follow-up research. So I will pass on to Isabel now. Thank you.
I'm trying to unmute. Superb. Thank you very much, Eleanor. That was, so detailed, and again, very impressive achievement as part of your master's project, and highlighting these key needs that we need to look for now. And so just touching a little bit further on this now, we're handing over to Isabel Gaban, who is a new Bloomsbury funded PhD student here at the RBC. She has a background in her BSc in biochemistry from University of Bristol, and then also did her master's with distinction with us here at the RBC in the London School. They're looking at schistosoma point of care diagnostics for that. And after a year working with industry, she's back with us to do this focused study upon the parasitology side of the hub. So here, at this early stage, as we'll see, Isabel's going to focus on what evidence, given this evidence gap we've seen raised in Eleanor's work, what evidence is there from the animal model system, particularly trying to look at these pregnant mothers around the perinatal period, and what evidence can this have? And again, then bringing it together again with what we will be doing in the hub over the next 2 years. So thank you very much, Isabel, and over to you.
Hi all, and thank you to Antonio and Eleanor for those great presentations, and thank you to Joanne for introducing us. So yes, I am a first year PhD student, and I'm looking at a systematic literature review that we've just started, really, titled "Do Helminthic and/or Protozoa Parasites Hinder Physical Growth, Weight Gain and/or Birth Outcomes?" And we're looking at evidence from animal models. So we've just seen from Eleanor in her paper that there are significant evidence gaps from the pregnant women and infants. And there's difficulties in determining association when stunting is potentially very multifactorial. So animal models provide us a useful system to disentangle the role of parasites. And our hypothesis is Helminth and/or parasitic protozoa infection, including infection of mother and offspring, negatively impact on physical growth, weight, and birth outcomes in non-human mammals. So why are animal models useful? Well, animals often have a shorter lifespan, particularly mice, for example. Mouse pups are in that very early period for only a matter of days, really. And you can observe a stunted phenotype in a much shorter amount of time, rather than following them for a number of years to find that stunted phenotype. Environmental enteric dysfunction, or EED, is a syndrome of inflammation, reduced absorptive capacity, and reduced barrier function in the small intestine, and it has been regularly linked in the literature to stunting. But there are very few non-invasive diagnostics available for EED in humans. It requires a gastrointestinal endoscopy. So we can sacrifice animal models and look at the ileum of the small intestine, like in this diagram on the bottom right. And like Antonio stated, there are few sensitive parasitic diagnostics for the field, such as the Cato cats, but we can sacrifice animal models and determine exact worm burden. And clearly there's the ethics of infecting a child and obviously treating or not treating a child. So quickly on my methods, I'm searching 6 databases listed here. Our participants are non-human mammals, and we're looking for animals that are infected with and/or exposed to helminths and/or parasitic protozoa of the gastrointestinal tract, and we're including all schistosoma species. And we're looking for comparison groups, and they have to be one of each of these 3, so infected and uninfected control, treated or untreated, or before and after treatment. So when I was doing my pilot studies, I didn't find that many papers looking purely at height of animals or length of animals, for example. So I decided to expand the scope of the review from Eleanor's. So, for example, we're including weights of animals, because we know that repeated bouts of wasting is associated with stunting. So if we look at weights, we can potentially look at how this is impacting on linear height or length. And we're also including the protozoa, the parasitic protozoa. Protozoa such as Cryptosporidium and Entamoeba, they cause significant deaths in children under 5, and they also cause diarrhea, one of the main symptoms. And we know that diarrhea is associated with stunting, so we decided to include these parasites as well. So the 3 outcomes that we are looking at are the anthropometric measures, so linear growth, so length of a mouse from the nose to the tail, or the length of the tail, or length of limbs, head circumference, as well as birth outcomes, so prematurity, and weight, so birth weight, wasting, body condition score for livestock. And we're looking at primary and secondary literature, as well as so peer-reviewed, as well as grey literature if they're found in our 6 databases. So similar to Eleanor's review, systematic literature review, we're using the PRISMA guidelines to optimize the quality of our reporting, the Cochrane handbook to guide our analysis. We're registering with Prospero, and we're potentially using Sirical, which is a risk bias tool, which is a adaptive version of the Cochrane risk bias tool that has been adjusted for animal intervention studies. So once we've got our data out of the papers, we wish to stratify our data, quite importantly, because there's a lot of very heterogeneous papers out there looking at how we're doing this. So host, species, breed, gender. Breed may be quite important for cattle, for example, when different breeds have different resistance, different parasites. The helminth and protozoa can be stratified, and more specifically the parasite species. And very importantly, the parasite burden has been alluded to earlier. When there's a low burden, for example, of worms, animal may be asymptomatic, but when it's a high burden, they may have a much more potentially stunted phenotype, or show more symptoms. And then importantly, age. We'd like to focus on the maternal, so in utero stunting and the neonatal period. So this might be different for different animals. So the neonatal period might be a few days for a mouse or a matter of months for cattle. And then diet effects, because regularly people will look at infection as well as malnutrition, for example, so normal nourished or low protein diets when they're looking at mice in the lab. So just some preliminary results that are quite interesting papers that we have found so far. We're in the process of screening at the moment. So mice experimentally infected with Cryptosporidium and Giardia, the infection contributed to weight loss in these animals. And in both cases, the Giardia and the Crypto model both showed exacerbation of weight loss in infected, malnourished mice. And in both cases, the animals were sacrificed and environmental enteric dysfunction or was shown in the ileum of the animal's small intestine. So on the right, we can see in this diagram, the top left, you can see the normal crypts. On the right top, you can see the slight atrophy, but on the bottom, you can really see the villus atrophy and the blunting, reducing the surface area, which may impact nutrient absorption. And also note at the top left, you can see the little black dots, which are goblet cells, which are important for barrier maintenance in the small intestine. And these are pretty much gone in the bottom diagram. As well, there's some papers on the linear growth, so from the tip of the nose to the end of the tail. So this is infection of the mother, of the maternal, of the mother mouse on the fetus. So Heligomoides infection of the mother resulted in a stunted phenotype, so shorter mice, and this was increasing in severity with the number of intestinal worms. And on the right, this is maternal infection with Heligomoides baccari, so a different species. The infection reduced the fetal crown rump length in mice. I thought it was quite interesting that you can see when there was no worms, the crown rump length had quite, apart from the one outlier, was quite a short range, a small range, whereas you can see the reduced length in the 50, 100, 150 number of worms of the mother. So here, looking at changes in livestock weights in treated and untreated animals. Firstly, so cattle treated with anti-parasitic drugs, albendazole and ivermectin, exhibited about 20% higher body weights compared to the control animals who were not treated. And as well, goats in India, after almost 2 months, being treated with albendazole, their weight was much higher than those that were not treated. And this is shown on the box plots on the right. And finally, there's pigs infected with trichinella were shown to be generally asymptomatic, but they had much less weight gain compared to the animals that were not infected, so about 15%, which is quite interesting considering they didn't show any other symptoms of trichinella. So potential mechanistic roles of parasites. So we've kind of, so what I've seen, there's an early indication from animal models that growth is hindered by parasites, but we want to know the mechanistic role of parasites. So if I just kind of speak about a few of these. So for example, parasites may cause appetite loss in a human, potentially through irritation of the gastrointestinal tract. And appetite loss may contribute to malnutrition and then potentially stunting. Breast milk quality may be impacted by maternal infection with parasites, although this one's quite interesting because the mother may also pass on antibodies to the child, which means that maternal infection might actually be beneficial in this case. A chronic low-grade inflammation caused by parasites. This may interfere with normal musculoskeletal development. Hematuria, for example, schistosoma hematobium causes hematuria and potentially anemia, which may contribute to stunting, growth retardation. An elevated immune response. So we know that immune function is energetically quite costly. So if calories, energy is being directed away from growth and towards an immune response, this may contribute to growth stunting. Diarrhea caused by parasitic infection. This may result in loss of micronutrients, energy, vitamins, minerals, etc. But we know that stunting is most likely multifactorial. It's not just parasites. And we want to uncover the synergies and interactions between factors underlying stunting, because factors are very interlinked. For example, the gut microbiome may impact which parasites may be able to thrive in the gut, but also parasites may influence the composition of the gut microbiome. So there's very interlinked factors at play here. So I'm working alongside the Action Against Stunting Hub, which is working in Senegal, India and Indonesia, where we've got cohorts of mothers and babies, and we're working to enhance global understanding of the drivers that lead to stunting. And there's a number of work streams for working on different parts of this, so parasitology, microbiome, epigenetics, etc. And we'll be able to come together to look at stunting together as a whole child approach. So I'm going to be undertaking some parasitology work, looking at samples collected in the 3 hub countries. So in the field, we'll be looking for soil transmitted helminths, schistosoma, so myristidia hatching techniques, urine filtration, chaetoid cats, which has already been spoken about, and then using more sensitive in the laboratory, more sensitive qPCR methods to diagnose the protozoa and helminth species again. And then we're using the hub data, the data we've collected. We want to look statistically at the relationships between linear height and other anthropometric measurements and parasite infection. And here, we like to do this to disentangle the potential associations between infection and stunting. And the benefit of working with the hub is that having the other work streams means we can include data as confounders from the same individuals, same people from the cohorts. This is really beneficial, and this is really great to have the hub for this. And then looking at outcomes, currently pregnant mothers and under 2s aren't recommended to have anti-parasitic treatment. It's mostly school-age children. So depending on our results, this might be something that we want to look into. Thank you for listening. Have you got any questions?
Super, absolutely great. Well done, Isabel. So yeah, 3 superb talks. Very well done to you all. I'm going to open up for questions now. We've just got a couple in the chat. We'll start with those. In the first one, we have Luinmar Lang. And so very much following on from what Isabel has been discussing, is the preventative effect of STH chemotherapy among pregnant women on low birth weight, as Antonia had shown as well examples, due to anemia reduction, or is there any other mechanisms? So Isabel has covered many of those. I'm going to put it first to Antonio. Do you think anything else to add here?
No, I think the anemia is very, very important. We have demonstrated directly the loss of blood when you have progressive high intestinal infection, especially with hookworm. I think this the loss of hemoglobin is the main reason. There probably also other things, but this is probably the main part.
Okay. And Eleanor, anything else to add there from your findings, from your literature review, any of the key factors that were coming out?
I think, as Dr. Montresor has said, it's likely to be that anemia is a big factor. I think at the moment where we have still relatively little data in relation to the pregnant women that have been treated, it's also difficult to say if there are other factors coming in. And as Isabel said, it's such a multifactorial issue that I think there could well be other factors. In particular, nutrition, I think, could be playing a role. And also, I think the gut microbiome aspects are still very much sort of in the infancy in terms of our understanding. So I think those could be some factors that we learn more about in the future.
Yeah, no, absolutely. And then Isabel, I mean, I'm sure you will agree with that. And then it was it. So do you, if it's, I think it's anemia, I think you'll be focusing a lot on things like the gut dysbiosis as well. But do you think then this is going to be something restricted to parasites causing anemia, or do you expect in both intestinal and other such as urogenital parasites, for example?
Yeah, and this is where it's really interesting having the hub coming in, because we have all of the data coming from, for example, the diet work streams and all the other work streams together, so we can look at the interactions between these factors. But yeah, I think anemia has been it's regularly cited in the literature as one of the most important. But I think the enteric dysfunction, it's quite a new factor being cited in the literature. So it'll be quite interesting to see, if that's potentially one of the factors at play here.
Okay, and on a similar vein, we have Okechukwu, sorry, Arabidor, sorry if I no doubt pronounce that wrong. But what do you think, and again, starting with Antonio, what do you think in terms of, is it possible that environmental factors will also affect the outcome of these parasites on the host, touching again on this interplay, this multi-factor?
Yes. Of course, malnutrition is like a bank account. If you can stop the losing of the money, but if you don't enter money continuously, that you never reach high level. So it's the same principle. So we have two way to improve the nutritional level, and both are to be done together. First, improve the nutritional input, and second, try to reduce the loss of micronutrients.
Okay, so Jean Bosco has a question, and I think this will be all relevant to all of you, but again, we'll start with Antonio. Why, we know that everybody cites Helminths as a role in stunting and in child health, but why do you think what are the issues for the under-research in this area when we know that stunting is such a sort of global intractable issue, and the SDH might be one of the contributing factors? Why do you think we have got these evidence gaps?
It's very difficult to have strong evidence from human studies, and this is why I appreciate very much the approach of Isabel for animal study, because in that context we can really know what is the situation in the affected individual, how many parasites they have, because basically if you're doing comparing treated and untreated person, as has been done in many of the trial, we are the treated people, most of them are not infected. Many of them are not infected. If you have 30% prevalence, I mean, the 70% of the treated people are not infected. So if you are calculating the average improvement in this population, you divide it by 3 or more, the benefit that the infected person receive. So at the same time, we cannot, in human health, keep a person infected and compare, because this will be the study. You keep a person infected with heavy intensity, and you take another person that you deworm, or a group of persons that you deworm regularly, and you compare. This is not possible in human studies because of ethical issue. You cannot maintain people infected if you know that this infection are negative for his health. So I think that we will get more information from the animal study than the human one.
Yeah. Anything? Oh yeah, Isabel.
Yeah, I want to say that with stunting, it happens over a number of years. When there's many people stunted in a population, it kind of becomes more normal for that population. Whereas if it's something more acute, then people want to, it's easier to say, okay, we want the funding for this, to research this.
Again, why these are, very good point, why these are the neglected diseases. And I think we've also got to consider that, these are very sensitive groups, particularly we've been looking at school-age children, but now when we're coming in, with pregnant mothers and the preschool children, then, again, these are areas that, little research has been going on for a while. I think just handing back to Antonio here. He's got his hand back up.
Yes, very, very short thing. I've been working in Vietnam for 5 years, and we have a very interesting group of people that was of Vietnamese that moved after the war or immediately before the end of the war from Vietnam to Europe and to US. These people were with limited nutritional input in Vietnam and with a lot of parasites. The percentage of prevalence in Ascaris, Securus, and hookworm in Vietnam is huge. So, and they were considered small as something depending on the race in reality, when these people move from Vietnam to Europe or to US, you see these Vietnamese young children very high, and they also play basket in the NBA. So I think exactly what Isabel was saying is sometimes being stunted is considered normal, and no one was really considered Vietnamese stunted, but most of them were.
Yeah, and on a similar, we're very much talking about Helminths. What's your opinion that we're getting more of these data because of the MDA programs are targeting Helminths because we have affordable drugs, safe, effective drugs? Do you think that's why we have less data on the protozoans, simply because we have less access to affordable and safe and easily treatable drugs for the protozoans? Do you think that's why there's a gap between the Helminths data and the protozoan data? Antonio, maybe?
I think so, in the sense that I think protozoa are certainly important. The point is we don't have a simple way to control them. Yeah. And we cannot distribute antibiotics, and then there are safety issues, there are side effects, while with the albendazole and bendazole, these are very safe drugs. People take the drug, this not even absorb or minimally absorb, kill the worm and go out. So for this, we are a strategy that's very efficient. They are very cheap, they are donated. So we have flourishing and scaling up intervention, while for the others, we don't have a solution. So probably this stimulated very little the research on that area.
Okay. And Isabel, on your early findings, are you finding any stronger evidence, you think, on the animal models and Helminths versus protozoa?
There's a mixture. There's studies showing in many of the studies are treatment studies, so in livestock, looking at weights because of the economics around this. So there's fewer, but most of these do show that anti-parasitic drugs improve weight gain. But with length and height, it's much more difficult to say because there's fewer studies out there. Yeah.
Super. A question here again for Antonio. I had a minute ago. Oh, it's gone. No, it was, I saw it a minute ago. Oh yeah. So from an anonymous attendee, really great presentations. Antonio, could you speak a bit more about how an individual would move from a low level to infection to a high level of infection?
Yeah, this parasite are more intelligent than bacteria, and they don't want to kill the host, basically. While the malaria parasite or other bacteria, they are reproducing. The worm, the eggs of the worm cannot hatch in the host. They should go out, stay in the water or in the soil for soil transmitted helminth, or water for the schistosome, and then infect again other people. So this is a way the parasite use, a strategy the parasite use to not to kill the host, because it's where they get food, shelter, nutrition, and everything, but to spread into the population. Of course, people can be infected multiple times, and therefore passing from a low intestine infection with multiple infection. Every worm you have in your body is resulting from eggs entering. So if you get in contact or you are infected multiple times, you can accumulate a lot of worms in your body, but it is something that takes time. So the strategy of WHO is to kill most of the worm periodically, not giving time to build the intestinal infection.
Okay, super. We have from Rona, who I think is in Uganda, to Eleanor. Would birth length be a useful in addition to birth weight? Certainly said within the hub activities, we're looking at length and weight. What was your findings in the literature? Did you find one better than the other? And how important do you think this is this distinction?
Yes, thank you. I think it's a good question. I think from my research and from our review, really the more data we have, the better. So if we do have people that are able to measure birth length as well as birth weight, I think that can be really useful, because in some cases it may be that we see differences with length, but not necessarily weight. It also depends how accurately you can record these things as well, in terms of the equipment that's available, and obviously, how accurate you can be with weight, whereas length potentially you can maybe get, pick up very subtle differences that are perhaps slightly more difficult to detect with weight. And the other thing I would just mention in regards to some of the questions that have already been asked is, I think it's important to remember that often the children or the animals are co-infected by more than one type of parasite. And I think that's a real strength of Isabel's work, is that she's looking at the helminths and the protozoal infections. And often we know with livestock, for example, they'll have a co-infection of a helminth and a protozoa. So I think that having the two together is really helpful, because it's difficult to try and identify animals or livestock with just a single infection in these situations.
Yes, indeed. Yeah, critical point. We're getting short on time. I'll ask a question now that quite clearly we've seen from Eleanor's finding, from Isabel's initial finding, and from these lovely studies that Antonio showed, that we potentially have this key period, this critical period with the first 1,000 days. We have things like the new pediatric formula praziquantel coming in. We can give albendazole, mebendazole from this now push from the preschool age children, which is from 2, and also to treatment of the pregnant mothers depending on the trimester. But do you think, Antonio, that policy in time will change to promote treatment in even younger infants, the the 2-year-olds, and what factors would be involved, and what data do you think would have to be provided to help sort of promote any sort of change in WHO and beyond policy to go towards even younger infants for treatment?
I think at the moment treatment is recommended by the WHO after 1 year. This is because basically children less than 1 year are breastfeeded, and they're normally not going too much around, so the intensity of infection, the infection are rare and very, very low intensity. I think it's true that that is important, that the weight at the beginning of the life of the child, but this is more a result of the pregnancy, in my opinion. So we should not treat the children of 2 months because they have no possibility to be infected in reality, but we have to make sure that the pregnancy that delivered this child is proper, the mother is well nourished and without parasite.
Yeah, no, that's absolutely true. And also, yeah, one of the beauty of the stunting, where we're looking in detail from 6 months when the children start moving around, that's the age we start predicting them to start showing infections, and where the sort of the qPCRs and light infections will pick up. We have Oscar Kurt, following on slightly from the Helminth protozoan discussions. Thank you for this great webinar. As medical parasitologist with field studies in Turkey and Nepal, I saw Giardia as the most common parasite in children in both locations. How do you rate Giardia on its effects on stunting compared to Helminths? Who would like to answer that one?
I suppose I should. Well, we're not actually sure yet. So I'm looking at the animal models. So when we've done some analysis, we'll know hopefully how Giardia is impacting on growth and weight in the animal models, but it would be really interesting to look at it in the humans as well. So hopefully the hub will know what kind of infection levels we're having of Giardia in our hub countries relatively soon, and then we'll be able to do some analysis to see.
Yeah, the qPCR will hopefully pick this up. One of the sort of, in the design, they're excluding diarrhea samples, which, will knock out some from the acute, but Giardia hangs around for a while. So yes, again, that's something we will be very interested in looking at. And again, bringing in a lot of the animal studies have found really interesting things is if you knock out the helminths, sometimes protozoan infections then almost take over. It comes back to what Eleanor was saying is, we have multiple organisms together and we have to look at that balance. So we could have a sort of differential balance. I see, there's no open questions. We are at the end of our hour. We could talk for much more, and it would be really lovely in maybe 6 months and a year to get you all back again, and for a longer webinar with the same speakers here and some extra when we've got more findings in. Just to say thank you all so much for, I think, we take off our mutes that we can and give our 3 superb speakers a round of applause. Anybody else going to
yours is now.
And just say thank you so much for all participating and asking such great questions, and looking forward to exciting steps ahead. So thank you again.
Thank you very much. Bye-bye.
Thank you. Bye-bye. So I think, Alessia, we will go over to our original.